Good morning.
Well, good morning. It is very nice to see you. For us here, it's very cold and rainy. Yeah, it's nice, but it's freezing. So, good morning, Dr. Rosensweet, and good morning to everybody who's coming up. Welcome, welcome. We have our questions, and shall we commence?
Let us commence.
I think we should commence. I have a gavel. I'll use it. Okay. Question number one comes in stating that there has been talk of a 5-day hormone break. Would this be considered cycling? And if so, Dr. Rosensweet, could you please explain what cycling means and should all women be doing this cycling?
Good question. Um,
Uh-oh.
the We're really talking about women who are in menopause being treated with ovarian hormones, compounded bioidentical hormones. My favorite for sure.
Sorry about that.
And the general theory is since hormone levels in a young woman drop very low just before her period, in fact, it triggers the period, and they remain low for a few days into the period, why not copy nature in that way? And once a month, stop the hormones, stop taking the estrogen, the progesterone, the testosterone, and the DHEA. And then there's various suggestions on how many days to stop, and that will sort of copy nature. Well, there's ways in which it's a good idea, but I want to explain why it's a good idea and when to use it and when not to use it.
Please.
The general theory there is that because these ovarian hormones are fat soluble, that means they dissolve into fat tissue. Just like anything that's fat soluble, if you take too much of it, it's going to build up in the fat tissues of the body. Like vitamin A, for example, is fat soluble. If you take too much vitamin A, because vitamin A is yellow, eventually you're going to build up so much vitamin A dissolved in your fat tissues that your skin's going to turn yellow.
You look like
Well,
a big carrot.
well, the hormones are not colored, but they will build up if there's overdose. Well, what if they're only overdosed by a small amount every month? Gradually, over time, you would still build up into a general body overdose. So the best practice around stopping once a month, if you stop the right amount of time, is that you'll prevent that gradual buildup of hormones getting stored in your fat tissues and thus build up into overdose in your body. Stop once a month, the levels are going to drop when you stop. So how long do you stop?
Yeah, right.
When we instruct women to do this, we have a very specific method to do this. We say, well, the most convenient time for most women to stop, not all, is on the first day of every calendar month. So they don't take their hormones on the first of the month, and they don't take them on the second of the month. And we see what happens. Let's say they don't take their hormones on the first day of the month, and they do fine. They don't even have any symptoms of insufficiency. And they stop for the second day of the month, and they do fine. They have no symptoms of hormonal insufficiency, but they're going to be draining. And let's say on the third day they get their first hot flash. What we learned is that it took 2+ days to lower their hormone levels significantly enough that they went into symptoms of insufficiency. even though they got a little lower on day 1 of stoppage and day 2 of stoppage, the strategic reserve of the fatty tissue hadn't depleted to the point where they got symptoms of insufficiency. But by day 3, they did. Our then instruction is, from now on, don't stop for 3 days, stop for 2 days. We don't need you to get that symptom of hot flash once a month. That's a little stressful. But if you stop for 2 days, roughly speaking, you're not going to do hormone buildup over time. That's the method that we use to instruct women to stop once a month. Let's say that they stop on the first of the month and they don't get a symptom of insufficiency till the 10th day. Holy moly, they were on significant overdose. Those hormones built up in the strategic reserve in their body, otherwise known as their fatty tissue, because that's what it dissolves into. And it took 10 days to deplete. Man, they must have really had a buildup there.
So that's not a good thing necessarily.
Yeah, it's a clue to overdose. We don't rely on that once a month stoppage to detect overdose, no way. We rely on 24-hour urine hormone testing to detect optimal levels in overdose or underdose, ultimately. And that's very important. It's an imperative, really. And because you won't figure it out by symptoms alone. At the other end of the spectrum, let's say the woman stops on the first day of the month, and by the afternoon, she gets her first hot flash. She definitely was not on overdose. Her daily hormone program was running real lean. If she's getting symptom alleviation at that real lean treatment level, and if she's testing by 24-hour urine hormone testing in the optimal zone of estrogens, testosterone, DHEA, progesterone, that kind of woman, we don't have stop once a month. She's not going to build up, and we don't need her to get a symptom once a month, because that symptom, that hot flash, is stressful. You simultaneously trigger some adrenaline. You don't need to do that. So even though there's that general guidance, well, stop once a month and stop for 5 days, that's not precise enough. That's why I detailed how you figure this out woman by woman by woman. Oops, once again, it's the same old story. You want to get this right, individualize it for every woman. So we don't have any set days of stoppage. Some women, we don't have them stop at all. If they're running a lean treatment program, lean meaning they're at the low end of how much they really need to protect their bones, their vagina, et cetera, et cetera. So there's no set rules there. So that's why I wanted to go into the detail.
And thank you for that, because yeah, it does state clearly 5-day hormone break. Would this be considered cycling?
Yeah. Well, yeah, in a sense, it's mimicking the cycling of a young woman.
Yes, understood.
But cycling has a broader meaning to it. Like when you say that a woman is cycling, she's also menstruating. And 99% of the time, in a woman who's in menopause, we recommend that she doesn't cycle, that she's not getting such robust doses of estrogen. For example, that she forms an endometrial lining and menstruates. So that's why I don't love that word cycling. It's sort of like just a metaphor. Why did I say 99%? Because there is that rare woman that really needs robust dosages. And we've talked about that before, and that's another subject.
Yeah. Yeah.
And then this Facebook user, would you read that question?
I will indeed. She says, do you recommend stopping at the first of the 4 women who are still having periods?
Another good question.
Oh yeah.
Well, of course, if we were to recommend stopping, we would recommend stopping for a woman who's still having periods on the first day of her period. We wouldn't be the first day of the month.
Yeah, right.
Now, in general, we don't necessarily recommend stopping. Here's why. A woman who's in the perimenopause, she's at lower hormone levels than she was when she was 20, and often symptomatic because of the low hormone levels. So what we're doing when we're treating that woman with compounded bioidentical hormones is she now has two sources of estrogen, progesterone, testosterone, and DHEA. One is her ovary, the other is what she's applying to her skin. Two sources. We use the source of what the estrogens and the testosterone that she's applying to her skin just to augment what's coming out of the ovary. It can't be precise because it gets a little erratic in the perimenopause, but we can even out that erraticness just by augmenting what's coming out of the ovary.
Mm.
That smooths things out. So she's got two contributors to her daily hormonal milieu. One is her ovary, and the other one is what we're supplementing with estrogen, testosterone, DHEA, and progesterone. And sometimes we'll just suggest that she just keep taking the compounded bioidenticals every day, just to keep her general body levels up. Sometimes we'll suggest that, yeah, you do stop the first day of your period. How do you figure all this stuff out?
Hmm.
You come up with an idea, like one of those two ideas, stop or not to stop, and you see how it plays out. If the woman who's in the perimenopause and is getting augmented, her ovary production is getting augmented by the compounded bioidentical hormones, our theory is, well, yeah, stop everything. Well, if she gets symptomatic right away, then our next month we do a different experiment called Don't Stop. See if we can alleviate the symptoms, because the symptoms are not helpful. In fact, they're stressful.
Oh yeah.
So once again, it points out the phenomenal guiding light for treating a woman in the menopause or perimenopause. Just individualize it. And we always like, best case scenario, that women themselves get a handle on this process and its many, many different moving parts, because the hormones are going into your body. And if you get an internal feel for them, you're going to be able to do some of these mini adjustments that I call individualization. And you're going to figure it out from the inside, which is why we wrote the book, Happy Healthy Hormones. And Carolyn has made that available on the ins and outs of menopause. No charge, download the PDF. So yeah, if you want to get active in the participation of getting your program correct, which I do highly recommend, read the book and you'll get more of an insight, and you'll see where all these answers are that I'm coming up with. Most of them are sitting in the book.
And you wrote it, so you would know. And it is a good book. And actually, just this week, I put out a lot of your book for a lot of women
Good.
that asked for it. Oh yeah, oh yeah, and and you can even purchase it too at this point, which is lovely. So I guess you can't see it, but behind me, I have quite a few. So anyway, Happy Healthy Hormones. Really, really, really good book. Thank you for writing that, Dr. Rosensweet. And
Mm.
thank you for that answer. Um, it's going to lead me into my second question, which we do get a lot, but it's important, I believe. And let me go on with it. Questioner asks, "Can you tell me, please?" And I know that so many women ask this question. I did myself. what optimal levels of hormones are?
Yes,
Thank you.
I can answer that question. And the answer is depends on the individual.
Correct.
So I'll give you the background to it first.
Thank you.
Women and men, we vary as individuals. We may have a lot of similarities, like we walk and talk and we breathe and eat, but there's individual biochemical and physiologic differences. And we represent a range of what's possible. There's no exact number for every single individual. And so, for example, you can have a young, healthy woman who's regularly menstruating, is fertile, she can conceive, carry a pregnancy, healthy. And she needs this much estrogen. I'm using this as sort of a bar. She needs this amount of estrogen to do that. Whereas you could have another woman who needs 3 times that amount of estrogen to have a period, be fertile, get pregnant. 3 times. Women fall within this range. You got to have enough. You can't be too low, but you don't need to be too high. So women vary that much. Men do too. So what's the right amount? It varies woman to woman. Now, there are parameters. For example, we know what that lower number is for a 20 to 29-year-old, and that upper number is for a 20 to 29-year-old. What that range of normal, let's say, estradiol is. We know what that is. Every lab develops these laboratory normal reference ranges based on statistical analysis. And it's always a range, no matter what you're talking about. Now, when you think of a young woman, I show you the range is like this. Where do we want to treat menopausal women? Do we want to replicate this? 99% of the time, no. We don't want to replicate this. And there's reasons. And it turns out that the optimal range comes in right below. Right below. Normal, regularly menstruating, healthy, fertile young women, this range. Treating women in menopause, 99% of them right below. And not too low, right below. You need a certain amount to protect the bones in the vagina, for example, which is very clearly defined in the medical literature. How much does it take? And in this case, of estrogens. And one of the things that I did is I went into the medical literature quite a long time ago, and I extrapolated the numbers, and the laboratory that we use for the 24-hour urine hormone test, they agreed with the science so much that they were willing to publish that on their reports for women who were testing in menopause, what that range is. Just to give you some numbers, when you're dealing with the 24-hour urine hormone test, a woman, when she adds up her potent estrogens, there's 3 estrogens, 2 of them are really potent, estrone and estradiol. When she adds up those 2, she needs at least 8 micrograms of estrone plus estradiol excreted into her urine over 24 hours. That will tell us that she's going to protect her bones in her vagina. That's clearly defined in the medical literature. If she goes above 14 micrograms of estrone and estradiol, she runs the risk of overstimulation of breast glandular tissue.
Yes.
And thus increasing breast density, and that's not acceptable. We don't want that. Increasing breast density is not a healthy situation. It turns out when I showed you this and then showed this, that it takes at least this much for a young woman of estrogen to have a regular period. And interestingly enough, every regular period a woman each month prepares for possible pregnancy. She goes through a proliferating phase where there's cells added to the uterus, to the endometrial lining, to be a soft landing for a fertilized egg. Nice, thick lining, rich with blood supply. All that came brand new once a month. And if she doesn't get pregnant, that gets shed in what is the menstrual period. Well, there's other things going on every single month. She actually starts preparing for possible breastfeeding each and every month. She gets proliferation not only in the uterus, she gets proliferation of breast glandular cells. You get cell division, you get new cells there. She's preparing for breastfeeding every single cycle. Women can feel this. Most women will feel a increased fullness as their cycle goes on. And then if they don't get pregnant, they'll feel that fullness quiet down, get less full, as she actually loses those additional cells. I mean, you want to believe in the divine, study the female menstrual cycle. It'll make a believer out of you. Well, in order to produce and prepare for lactation, even as early as every single menstrual period, you got to produce new cells. You've got to have cell division. There's a delicate phase during cell division called mitosis. And mitosis is a vulnerable place for genes and chromosomes. So in a menopausal woman, 99% of the time, we do not want to see mitosis in a midlife woman. You don't need it. You don't need cell division. You don't need new breast glandular cells. We don't want breast glandular cell proliferation. So it turns out that the lower limit for a young, healthy woman to actually menstruate and go through that cycle and also get breast glandular cell proliferation, that's the upper limit of what we treat 99% of women with in menopause. 99%? Yeah, there's exceptions. There's no rules. There's no fixed rules in medicine. There's some women who really need robust levels of estrogen to protect their brain and to alleviate cognitive challenges. And sometimes they need really rich levels of estrogen. Some rare, but some of them even need to get such rich levels of estrogen that their period comes back. I mention this because there are exceptions. So if you need a number, the only place I've ever seen it is in the medical literature, and it takes between 8 and 14 micrograms of estradiol plus estrone excreted over a 24-hour period to be what we consider to be the optimal treatment zone for women with estrogen. For the androgens, testosterone and DHEA, we like to, most women do really well preserving their muscles. Oh my God, preserving the muscles. This is one of the most important things you do because you need testosterone to preserve those muscles. Testosterone is not a male hormone. It is a human hormone. Women have more testosterone than they have estradiol. Young women. So I'm trying to break up any conceptions might have that testosterone is a male hormone. It is not. It is a human hormone. Women need it. So to preserve the muscles, which is the bottom line in treating with testosterone, we like to, most women will do really well at the low end of the range of young women. We know what those numbers are on 24-hour urine hormone test. Some women we get a little richer, especially when it'll bring back a libido, though there's many moving parts to libido. And then testosterone, like all these hormones, are so powerful that if you take too much, you usually get symptoms. Like if you're taking too much testosterone, a lot of women are going to get acne. They're going to get real oily skin. They're going to get mustache area and chin area growth. So there's some inner protection there as to how high you're actually going to go. So those are the ranges. Progesterone, we really like to maximize. What I mean by that is we'll start a woman on low levels of progesterone. We'll have her gradually increase. We'll have her take it at bedtime because it helps calm and helps her with sleep, although some women take progesterone to good advantage during the day. And we'll keep on increasing that progesterone being the great calmer. If you take too much progesterone at night, you wake up the next morning with a hangover like you took a sleep overdose of a sleeping pill. Well, that tells us there was too much the night before. So we back the dose down. And we like to keep it right up at that upper limit there for most women because it protects the bones, it helps lay down new bone, it really protects the mood. So we behave a little differently with each one of these hormones. And then I'm laying down generalized guidelines. The real excellence is in the individualizing.
Mm-hmm.
Some women don't tolerate progesterone.
At
So
all.
you
Yeah.
never have a guideline like maximize progesterone. No, you got to individualize it for every single woman. And there's ways to do that, and we describe the details of that in Happy Healthy Hormones.
Yes, and well, I might add, um, and thank you so much for that. There is a question that came up. I'm going to hang on that one and go to our next question because I also think this one's important too. These next two for sure. Dr. Rosensweet, from what I understand, estrogen will dilate the arteries, and if the arteries are stuck and have plaque, it could cause a cardiac event. I had a great cardiac workup and I'm okay, thankfully. But the way that estrogen stimulates this makes me very concerned. I've not been without hormones for 10 years, not even 5 years. But this particular fact really concerns me, and I was wondering if you could elaborate on that.
Yeah, this is a very interesting phenomena here. It really speaks to the many advantages of starting to replenish hormones when a woman is young.
Mm,
When she enters the perimenopause, when she's starting to get symptoms of hormones being too low. But it doesn't, I would never hold that to be hard and fast. Our general rule with the menopause method is whenever we get an opportunity to treat a woman, let's start and celebrate it. So, for example, I didn't start treating my mom till she was 86. That's not like I didn't want to treat her before that, but she didn't want me to mention females nothing and talk about hormones. And I didn't start treating my mother-in-law until she was 85.
and they had never had hormones.
And they had never had hormones since menopause, and they both had advantage to doing that. So, whatever age you're fortunate enough to say, "Gee, I think I want these," get them.
Do it.
Find someone who knows what they're doing, and take these hormones. And you'll get advantage out of it, most likely, and sometimes significant, major, humongous advantage, not just little advantage. Like my mother-in-law, she was able to get out of a walker, and she was heading towards a wheelchair. And then she didn't need a walker or a cane because we replenished her hormones, and through the androgens, testosterone, she got her muscle strength back. So it's a big deal. Now, what the questioner is pointing out is there is a rare exception here that we need to pay attention to. And we do. That's how we operate. So when I hear something, when I'm meeting a patient for the first time, and she's a woman who said, well, my last period was 5 years ago or it was 10 years ago, and I've never been treated with hormones, well, we approach this woman in a different way. And it's because of this rare possibility that's kind of odd. And one part of it that's very understandable is estrogen confers profound protection
Ah.
the arteries in women. Profound protection. Men have estrogen too. And men who do not have sufficient estrogen, these are the men that you hear about, never sick a day in his life, had a heart attack on the tennis court at 42. These men did not have enough estrogen to protect their arteries. And they're the ones who got arteriosclerosis. And the final action was usually a blood clot that formed on the barnacle surface of an artery. When it's not protected, it gets weird. It gets like rough arteriosclerosis, sclerosis, scarring, calcium deposits, cholesterol deposits, which is a perfect trigger to blood clotting. So when you hear of someone dying of a heart attack, it's not the arteriosclerosis that got him. It was the clot that formed on the roughened surface of the artery. And where does it most commonly form? Under the high hose pressure situations, like the arteries that come to the heart. They're getting some of the strongest pressure that happens, because they happen right away, right as the blood leaves the heart. So yes, it's the arteriosclerosis that is the trigger, but it's the trigger for the clot. And it's the clot that ends the life or causes a heart attack of people when you hear that they had a heart attack. Now, this unusual situation is possible and rare in a woman who, in menopause, she loses her estrogen. Gone, or all but gone. So she loses the protection that she had for her coronary arteries and all of her arteries, her cerebral arteries. She loses that protection. And she gets vulnerable to getting arteriosclerosis. It's not a guarantee. There's other moving parts. And if she gets arteriosclerosis, she's vulnerable to getting a clot forming on that arteriosclerosis, otherwise known as the thrombus. And what this questioner is talking about is this very unusual situation that a woman who has not had hormones, the magic number is 10 years, but we never go by that number that the medical literature mentions. We put a lot of factors together to decide when we're going to really investigate this. Could be 5 years without, could be 3 years without. Depends. If she's got a family history of arteriosclerosis, for example, we're going to test her earlier. And what we're looking for in testing her is, does she have a clot that's formed on an arteriosclerotic artery? Because there's this 1 year window that if you start treating a woman who hasn't had hormones and she's got coronary arteriosclerosis with a thrombus, there are some women where that thrombus is going to break loose and that will cause an embolus and that'll cause a heart attack. Unusual, rare. The oddest thing about it that I've never figured out is this woman is only vulnerable for a year. At the end of the year, she's no longer vulnerable. So if you started treating her with hormones, her vulnerability, even if she has a clot, is only 1 year. Go figure. I've never been able to explain that. But we never let it get that far.
Right.
So when a woman, and this questioner has done the right thing. Now, she said she's had an excellent workup by her cardiac workup. Well, we're very specific about what that cardiac workup is. When a woman says to me, I've been in menopause for several years and I want to take hormones, we say fine. But one of the things we're going to do is we're going to get a clearance from your cardiologist. And the bottom line is we want to go so far with that cardiologist to make sure you're not sitting there with a clot in your coronary arteries because you lost the protection of estrogen. Anyone get the moral of this story? Start estrogen as early as you possibly can. Protect those arteries. So we want something at least as rigorous as the stress ultrasound or the nuclear stress test. There's other ways to assess a clot. Some of them are even more technically sophisticated, like a cardiac catheterization. But we don't need you to go that far, but we do need you to go as far as a stress ultrasound or a nuclear stress test. That'll tell us whether there's compromised arterial circulation to your heart, thus most likely caused by a clot. So we have those women do that. And some women, when there's even more risk factors, will also do a coagulation profile because it's not about the arteriosclerosis, it's about the clot. And what we know about Americans is there's an increased propensity to clot. How in the world did that happen? In the delicate balance between let's be sure we clot, if there's some kind of skin wound, like a javelin thrust into our, I won't go further.
Just
But
happened.
we don't want to clot. We don't want to clot too easy because we'll get intravascular clotting. It's delicately poised. Well, if someone is leaning towards clotting too easily, we want to find that out, and we can by sophisticated blood testing. There's laboratories that do that. So sometimes we'll do a combination. We'll do an arteriosclerosis, thrombus, is that there? And we'll do a coagulation profile. So it all depends about the individual patient, about how far we need to go. But all that does is, it adds some technicality, but we've done this many times. Who loves to go to the cardiologist and get an echo stress test or a coagulation profile? None of us are eager to rush off to our physician and spend some time doing things. But we're careful and we're vigilant. How often do we turn up trouble? Very rare. But all you got to do is turn it up once when you're a doctor.
Ooh.
And save somebody the grief of that risk. And then you realize, hey, this is worth it. This is a miracle that we have these tools. Mostly what we like to do in the menopause method is get the clearance of an actual cardiologist. They know what we're talking about and they know how to do it. So
quite true. Yeah.
Now the other thing I want to say is, I don't want it to slip my mind. Yeah, here's what it is. That protection of estrogen is so strong that it's very, very rare that you hear about a young woman passing away of a heart attack. And it is rare, but it's not that rare that you hear this story of this young man in his early 40s, never sick a day in his life, had a heart attack and passed away. The incidence of coronary artery disease and heart attack is much higher in young men than it is in young women. However, by the age of 60, that incidence in men and women equalizes, so much so that half the women and half the men who leave the planet Earth, we all seem to do that,
Oddly.
leave the planet Earth because of the consequences of arteriosclerosis, whether it's heart attack or stroke. So to me, it just points out how critical it is to, when you're treating young men, to make sure that they're getting enough estrogen. It's pretty uncommon that you're going to find a man with a low estrogen, but when you do, you treat him.
It's
not
very
to bring his estrogen levels way up, but to bring him into a safety zone.
right.
And when you're treating a young woman whose ovaries are no longer doing the full job, we keep her estrogen levels right at a rich enough level, hopefully to protect those coronary arteries under most circumstances. It's that important. You want to live long and prosper. You want to reduce the risk of stroke and heart attack. Start those hormones as early as you can.
So this is going to lead me into my next question.
Yes.
Because it really does tie into
The final thing I want to say there is that if you don't start them early, start them whenever.
Anyway.
We got ways to assess ways to assess you and keep you in the safe zone. So
So
whenever you feel inclined to start them, even if you're in your 60s, 70s, 80s, 90s, start them whenever you get the opportunity to.
cannot say I agree more. A question just came up before my other question, and it's from a gentleman who says, "What is the estrogen safety zone for a 40-ish man?" Does that go back to what we were talking about?
Well, the subject of men and estrogen levels is so extensive that I don't want to give you an exact number. But when we see lowish estrogens, like 20 in a young man or lower, everyone's got their own marker. We start wanting to evaluate further. So I can't give you an exact number, but a lot of more young men are getting their estrogen levels tested, and that's a good thing. And then who's ever treating you, usually they're getting their estrogen levels tested because there's erectile issues coming up.
Right, right.
So that provider will have the education and will be able to look at your whole constellation and give you the proper answer, which is let's look at your estrogen levels, let's look at your coronary artery markers, let's do a stress test on you. Let's see how far we got to go.
Cool. I like that. I'm really glad that question came up. And thank you for answering it. Uh, the question I wanted to follow up with is a woman writes in and says, "A long term compounding pharmacist I know told me that estrogen is in a group of carcinogens, and perhaps I should really shy away from taking any of the estrogens at all."
I love compounding pharmacists. I know so many. And these are some of the most educated and rigorous folks out there. And they're the ones who are compounding the hormones and making these preparations. And they too were subject to some false information that came out. And with all due respect to your compounding pharmacist, excuse me, the information that he just mentioned is false. Now, this information was exploded out onto the planet and the people of the planet Earth and the healthcare providers and the women especially in 2002. For 1,000 years, we always thought that it was beneficial to treat women with estrogens. 1,000 years. And then in 2002, there was this big study that came out that said, what it really said was there was no increase in risk. That's what it really said. But what one of the lines, when it was explaining risk, said that there was increased risk of breast cancer, heart attack, and stroke. And that was immediately followed by, but that increased risk is statistically insignificant. And here we're talking about two hormones, Premarin, pregnant male-derived estrogen, which conferred a lesser risk for breast cancer, heart attack, and stroke, 0.79, less than 1, lesser risk. And the Prem-Pro, this combination with this progestin, showed a 1.26 increased relative risk, which is so minor that it's statistically insignificant, which means in medicine and in science, don't draw any conclusions, folks. You haven't got the evidence. But the press didn't deal with the statistically insignificant statement. They just said increased risk. And it exploded out into the American and the world public and all the healthcare providers, including compounding pharmacists who were dispensing these hormones. And all of a sudden, there's this new thing called estrogen is carcinogenic. Now, I want to dispel this risk. That is not true. What we know from study after study after study, including that Women's Health Initiative study, that estrogen protects against breast cancer. I'm lingering there because I want that to reverberate and echo in the air. Estrogen protects against breast cancer, heart attack, and stroke. That was always so. The original study committee published in 2016 or 2017 a retraction of their original work. They published it in the same journal that the original study was published in. They said after 18 years of follow-up, there is no increased risk for breast cancer, heart attack, and stroke. That's all they were willing to say. They weren't willing to apologize. We knew right out of the gate that there was many things not correct about that study. But it was too late. I mean, this explosion, the cat got out of the bag, and you could not get that cat back in the bag. Pardon me.
Very frightening to very, very, very many people. Doctors, compounding pharmacists, women, husbands of women.
Precisely.
Horrible.
So now let me try and clarify what the information actually is. And if you want what I consider to be an overview and a very good summary of the actual risk information, it's in Chapter 3 of Happy Healthy Hormones. And if you really want to learn about it, there's a breast cancer specialist, an oncologist named Avram Blooming, and his partner, Carol Tavris, his science partner, called Estrogen Matters. And they go through the science with 450 references to the medical literature.
Yeah, he dug in. They dug in.
And here is the science. We're all at risk for thousands of diagnoses. A lot of them not easy. Tough. Doesn't matter how tough it is, someone on this planet has healed whatever that diagnosis is. We're all at risk for hundreds of cancers. As a male, I have a relative increase in risk for prostate cancer. There are reasons for this. Women are at increased relative risk for breast cancer. There are reasons for this. But even though there's those increased relative risks, women who are treated with hormones are at less risk for the development of breast cancer than women who go untreated, do not receive hormonal treatment. Less risk. That's the science. It even goes so far as women who've had breast cancer have an increased relative risk for recurrence of that cancer as compared to a young woman who's never had cancer has to getting it. But women who have had breast cancer and had that breast cancer properly treated are at less risk for recurrence if they are treated with hormones than if they are not. Hormones do not cause cancer. In fact, ovarian hormones like estrogen, for example, protects against the development of cancer. Now, cancer has causes, and a lot of them, and I won't go deep into that today, but I want to just leave you with that women who are treated with hormones, even if it's Premarin and Prempro, are at less risk for breast cancer, heart attack, and stroke than women who go untreated. So I'm sorry, with all due respect to your compounding pharmacist, he is not up on, or she is not up on the latest information. And, you know, although almost everyone has their ear to the railroad tracks, so to speak, who's paying attention to breast health, whether you're a woman or a man or a healthcare provider, anyone who's paying attention is deeply familiar with the story that estrogens cause cancer. It's a false story. Even though this has been retracted, there's very few healthcare providers that have become aware of this information, that study was falsely reported,
Right.
and that the information is false, and that the opposite is true, that estrogen protects against cancer. So your compounding pharmacist is not alone. It's really what prevails. We talk to healthcare providers all the time. Sometimes they're surprised because they've drank the Kool-Aid that there's increased risk, which is false.
Right. And
So not to single out your compounding pharmacist as being unusual, it's much more the rule that even healthcare providers have not caught up with the most recent evidence. Now, there's a lot of scientists and physicians out there pounding the pavement, trying to say, wait, that stuff was incorrect, and you're doing a lot of damage by not treating women and men. And look at what the science is. Yes, we're all at risk for cancer, but we're at less risk for cancer if we're treated with estrogen.
That's so important.
So there's people out there trying to reverse that. And you know what? It's creeping in. More and more, I'm seeing studies. They just did a 7 million woman study of women in Medicare that showed that it was protective. Just published that. So the good work is being done to retract that horrible rumor. Because why I say horrible? Because a lot of women stop taking hormones. And those who are not taking hormones, it's not a risk. It's almost a near certainty that you're going to lose muscle, going to wind up with canes, walkers, wheelchairs, and loss of control of your bladder. You're going to lose bone. You're going to be subject to fracture. Many people are going to lose the cognitive ability by not getting hormones. They're going to lose the protection to the arteries. And on and on and on.
Right.
So it's highly consequential. It's one of the most misogynistic events that I've witnessed in my career as a physician. How in the world did that misinformation get out there and cause so much damage to so many women? Same thing for men. The whole study, the whole thing that testosterone caused prostate cancer was absolute opposite and false. The actual science is there's less risk if you have normal testosterone levels.
Wow.
So, yeah, again, the science is that women who are treated with hormones, principally estrogen, are at less risk for breast cancer, heart attack, and stroke. That's the science. With all due respect, the information you got from your respected compounding pharmacist was incorrect. And you could refer your compounding pharmacist to Dr. Blooming and Dr. Tavris's book called Estrogen Matter. The science is there.
It's a good book. And there's an interview, too, that you can listen to where Dr. Tavris and Dr. Blooming both are interviewed as well. And you can always write to me, and I'll give that to you, on the ins and outs of menopause page with David Rosensweet, MD. This question, we have just a few minutes. Let me give it a shot. Actually, you know what? I'm going to save that for my first question. Again, I'm getting a question here saying waiting for the Bright program. So we want to know what the update is on that, Dr. Rosensweet, if you have one.
We do. There's progress made. What the Bright program is we're going to be able to offer to women all 4 ovarian hormones for $99 a month if you get in on the ground floor here. And we're very excited about it. It's the biggest breakthrough I have personally seen in treating women in menopause to make it affordable.
It's huge.
And there's so many moving parts, including this internet technology part, to be able to properly write the prescription and do the charging, that's what there's a whole team in motion, doing great work. We love them. They're really into it. And I never realized how much it takes to do the internet stuff in order to get the prescription sent and the simultaneous charging done properly. So we're close. Best hope, I know I keep saying this, best hope is we can start the pilot program, which will be with all the menopause method patients. And once we see that the wheels are working, I'd say 2 weeks to the latest 2 months.
Oh my boy, the minute that I get the go ahead from you.
We'll let you know. Yeah, of
Yeah.
course. We're very excited about it, and there's a lot of people working on it now. And the pharmacy has all the equipment now. They're getting set up to do it. So it's this final internet technology piece that is being
It's
put together.
amazing. It's incredible. It's incredible. Yeah. Unbelievable. I mean, it almost brings tears to my eyes because it's going to really help a lot of women. And wow, we can't thank you guys enough. I know who this team is, or some of them. And what a great team that is. Headed
Yes,
up
it.
by a really great person, too. I'm looking at him. So, with our last few minutes left, maybe you can answer this quickly. Does progesterone trochase affect the liver or the kidneys?
No,
Okay.
and elaborate a little bit. Troches are like these gummy bears that you stick under your tongue, and it's a sublingual delivery system that works in a lot of ways. It works great. Where I love it the most is within something called nitroglycerin. For people who have coronary artery issues and they have chest pain and they pop a nitroglycerin pill under their tongue, you get rapid absorption into the bloodstream. I'm not such a fan with hormones because anyone who's stuck anything like under their tongue realizes that if it takes a while to dissolve, you wind up swallowing part of it.
Yeah.
And not only that, the part that does make it into the bloodstream under the tongue rushes in rapidly and raises the levels quite highly. And we much prefer a slow, steady, gradual, and even rise that you can get on the skin when you apply progesterone to the skin, for example. But when you get something under the tongue, you get two things happen. You get peaking of the stuff that gets in immediately, and you get swallowing, which is a much slower route and not as controllable dosage wise. So for that reason, I don't like the erraticness of troches. Don't need the peaks and can't really control what percentage is swallowed and what part goes under the tongue. Now, having said that, progesterone is so safe that it doesn't matter that it goes under the tongue and that you swallow it or you swallow it. There's going to be no damage to the liver. That's not true with testosterone, for example. You don't want to administer testosterone in a trachea or oral. You can get liver damage from that. But for progesterone, you're fine. There's no harm done. To me, it's just not the most elegant way to do it. The most elegant way is topical. And if you feel like you're going to need a different route, oral works really well with progesterone, not with estrogen. It's definitely not the ideal for estrogen. Some people get clots from estrogen. There's reasons why that's so. And but for progesterone, oral is fine. So the troches are fine. They're no big deal. And if someone were to say to me, well, I really prefer the troches because that rapid action makes me sleepy right away, I'd say, bravo, keep taking your troches. You're going to be fine.
Yay, yay. Okay. Look at that, right on the mark. We made it.
Holy
And
mackerel.
we even added in our chat questions. I'm very excited. So I wish you a really wonderful week, Dr. Rosensweet, everybody else too, and great weekend. And we will see you again next Tuesday.
Yes.
questions ready?
Yep. And thank you, Carolyn, once again.
My pleasure, really.
All right. Bye-bye
I'm
now.
going to see everybody later. Bye.